Made it through the spinal tracts, and now I want to take a moment to talk to you guys about the different lesions. I went ahead and took a picture of what I found just Googling what different areas of the cerebrum can be affected based upon if you have a stroke of each respective artery. Here you can see that the anterior cerebral artery will cover here. This is important to know because you remember your homunculus where the guys where you have a very large face and lips here out towards the side of the brain, and then you have large feet here. This is significant because usually if you have a MCA stroke or something like that, you think, okay, they're going to lose feeling because it's going to be in the post-central gyrus, so you're going to lose feeling to the majority of your body, but for some reason your legs and feet are spared. That's because the anterior cerebral artery will handle most of the lower leg and feet. So imagine your homunculus guy where his feet and legs are out here and then they're dangling. Your anterior cerebral artery will capture that part. And then here you have just kind of like your basic other parts of the brain that are covered through your cerebral arteries. Another important point that I don't get to later on in the PowerPoint, but it is super important to know, is the difference between a Bell's palsy, which is complete facial paralysis, and a stroke. With Bell's palsy, it's specific to the facial nerve, and a lesion specifically to it, particularly after it leaves the brainstem. Whenever you have that, both the top half of your face and the lower half of your face are going to be completely immobile. So if you were to ask somebody to smile, open their mouth, or close, or show their teeth, only the face that is unaffected by the lesion will be able to do so. However, whenever you have a cerebral vascular stroke or some sort of transient ischemic event of some sort, obviously this is going to be on the patient's left cerebrum, and the stroke symptoms because of decussation and crossing over are going to be present on the right side. The upper half of the face also receives innervation from the same side as well as the opposite side. So even though the stroke will happen on the patient's left side, they will have what's called forehead sparing because the top half of the patient's face is dually innervated from both sides of the cerebrum. So if you ever see a patient where they see they are unable to open and close their eyes at will, in addition to mouth drooping, you would know that would be a facial nerve palsy or a Bell's palsy, as opposed to somebody that's able to open and close their eyes perfectly fine, but their nasolabial folds and their mouth begin to droop whenever they smile or frown. So that's a very important point that I don't get to later in my PowerPoint, but it is something that you should know clinically moving forward. Before I get into the different lesions, I wanted to kind of take a mindfulness break and go over embryology. This is super high yield for both your clinical exams and for boards, knowing the origin of each of them. There is no really great way of remembering each of these different things. Just knowing what ventricles and what structures or cavities come from each of them. I know the easy one for me was always mesencephalon. That means the middle cephalon, and middle equals midbrain. Another important point to know is that your metencephalon has two structures. So a good way of kind of keeping that straight in my head was met has a T for two. So you would have your pons and cerebellum. Probably a good way of going about doing it is just writing these out on a board, and then they obviously just kind of follow along after you get this part down, knowing that it comes from the top down, your cerebrum from your telencephalon at top, your diencephalon, your thalamus, your midbrain, your mesencephalons in the middle, then your meta and myelo here at the bottom. So once again, starting from the cerebrum all the way down through your brainstem, and then finally your spinal cord. But a big reason why I wanted to bring this up, this is especially important when it comes to the cranial nerves. When embryologically, you will have what's called your alar plate and your basal plate. Your alar plate up here and your basal plate here. The way I remembered alar is for afferent or sensory, so alar is afferent. And these guys Thanks in large part to the ventricle and fourth ventricle that's going to be built, the sensory are going to end up going lateral, and then for the spinal cord, they're going to be posterior. So if you've ever wondered why you have your afferent or your sensory in the back and your motor or your efferent in the front, that's because you have your alar that start out posteriorly whenever you're developing. So once again, alar for afferent and basal for ventral or efferent / motor. And like I said before, thanks in large part in the brainstem, because we have this fourth ventricle, your sensory don't really have a way to stay in the back, so instead they move laterally. So any of your cranial nerves like 3, 4, 6, and 12, those all come to mind for me immediately. Those purely motor cranial nerves are going to remain right at the midline in the brainstem. However, ones that are purely sensory, like cranial nerve 8, what are some other purely sensory ones?
I found this on the web.
Your purely sensory nerves are going to be more on the lateral aspect of the brainstem moving forward. So just kind of keep that in mind as we work our way through the brainstem and all the different lesions that come about. So we'll start, since we just got done doing the spinal tracts, is the spinal cord lesions. These ones are just kind of good ways that test makers, whenever they're trying to like specifically target a tract, how they go about doing it. Probably the most easy one to make is from Brown-Séquard syndrome. That's a complete hemisection of the spinal cord. We've talked about this before whenever we were going through just kind of like the general rules. Because this is below the decussation of the corticospinal tract and below the decussation of the dorsal columns, it's going to be ipsilateral for those two. So we will have a loss of motor function on the right side, and we will have a loss of fine touch, vibration, and mild proprioception. Thankfully, the cerebellum kind of helps cover it, but we will have a loss of that on the ipsilateral or right side. However, because we've talked about this before, the spinothalamic tract has already decussated here, we will, at the level of this, at the level of the lesion or the Brown-Séquard lesion, it will be a loss of the contralateral side. In addition to, we will lose everything below that will be on the contralateral side. Yeah, I'm just trying to think. Sorry, neuro is such a screwy thing. But for spinothalamic tract, as opposed to the corticospinal tract and the dorsal column, the spinothalamic tract will have a decrease. Will have a loss of pain and temperature. Contralateral as opposed to ipsilateral. But at the level of the spinal column, because we do have at least one spinothalamic nerve coming through here, at the level it will be ipsilateral, but it will be contralateral below all that. And it has it listed here. Okay. So now we need to try and find ways that specifically target specific tracts. So how do you do that? You have different pathologies. The syringomyelia, because like our spinothalamic tracts will have to cross through this commissure here. That's how that tract is specifically targeted, and the other tracts don't seem to be as affected. Here it does note that you can have like some muscle weakness, because as it starts out here, it will spread and eventually get to the ventral horn where the corticospinal tract synapse is at. But the big thing here is they are specifically targeting your spinothalamic tract, aka your pain and temperature. So you because it has to decussate right here at this commissure for both the left and the right, you can see bilateral loss of pain and temperature. This thing you should be somewhat familiar with, thanks to biochemistry, is a loss of B12, we talked about if you're a chronic alcoholic, how you lose like your intrinsic factor, and so you lose the ability to absorb B12/cobalamin, and so you aren't able to myelinate a lot of your nerves. Specifically, your dorsal columns tend to be ones that get affected the most, along with your lateral corticospinal tract. So if you ever see somebody that is a chronic alcoholic and they seem to be stumbling or have a lot of ataxia, that could be in large part due to a loss of dorsal columns. Most likely they would have what's called a positive Romberg test, where they are unable to stand straight whenever they close their eyes. And they would also seem to have a little bit of a tremor or muscle weakness whenever they're trying to take out an action. And fortunately, thank goodness, polio has been eradicated. But it is important to know why polio was such a bad mamma jamma, is it specifically targeted the corticospinal tracts within the ventral horn of the spinal column. So once again, this is just a way of test makers trying to find a way to target specific tracts without having to go through the ischemia or loss of blood vessel route. And tabes dorsalis, this is a result of neurosyphilis. This is tertiary syphilis. This is the last stage of syphilis located in it. And this will specifically target the dorsal columns of the spinal column. So for anybody that's had syphilis that has been untreated, they will have a loss of proprioception, vibration, and fine touch. Once again, this person, if you suspect that they might have tabes dorsalis, you would have them close their eyes, stand up straight, and see if they sway more than they should. We'll get into this with the visual fields, but they will also have what's called an Argyll-Robertson pupil, where they will be able to accommodate or be able to track your finger as you move it close to their eye, and their pupils will constrict. However, if you were to shine a light into their eye, the pupils would be unable to constrict as a result of you shining a light into their eye. ALS, this one is specifically targeting the corticospinal tract. This one will do both the lateral aspect of the spinal column, so getting all the up and down tracts, the elevator tracts of the corticospinal tract, along with the ventral horn specifically. So you would see a lot of like muscle paralysis, increased muscle tone because this is a upper motor neuron, or you could have some flaccid paralysis as a result of having a lower motor neuron injury. And finally, this one is a kind of a popular one for the spinal tract. So you have your two vertebral arteries, and then they converge together going down the spinal column, forming the anterior spinal artery, right? So basically it covers the 2/3 of the spinal column, where the posterior 1/3 are spared. So basically the entire spinal column, with the exception of the dorsal column. So you would have bilateral loss of pain and temperature, and bilateral muscle loss. So you would not be able to use any of your muscles, and you would present with complete loss of muscle tone. Okay. So before we get into lesions, where we'll be talking a lot about the brainstem and where to find all of the different nuclei for the cranial nerves, it's a good kind of refresher to go back over and remind ourselves what the cranial nerves do. Most of this is probably going to be a review. Shout out to Emily Hudspeth for letting me borrow her slides. They do a great job of kind of summarizing each of the actions. But here's kind of the big thing, is the olfactory cranial nerve 1. That one is your sense of smell, so that's sensory only, and that one will go directly to the cerebrum, just like cranial nerve 2, which is your optic nerve. That one is sensory only, and that one will transmit the signals back to your brain, to your occiput, so that way you can take in images. I don't know how else to say that. Oculomotor handles most of your eye movement. Remember our mnemonic: LR6, SO4, all the rest are 3. The oculomotor will send signals to the Edinger-Westphal nucleus in the pretectal area of the occiput area. And then cranial nerve 4, that's the SO4 and the LR6, SO4, all the rest 3. That one is a strictly motor only, just like cranial nerve 3. Trigeminal, that one you have your V1, V2, V3. That will do sensory of the face for the V1 for above the eyebrow, below the eye for V2, and then your chin for V3. Chin and upper lip for V3, rather. And then it's also a dual nerve, so that means it has sensation of the face, but it also does general sensation like pain and touch on the anterior 2/3 of the tongue. It does your tensor vali palatini, and it's also important to know that it does your muscles of mastication. So think of what's the word I'm looking for? Like your masseter for V3, lateral and medial pterygoid muscles. And I think that covers 5. 6, once again, LR6, so abducens, so it's your lateral rectus muscle is going to pull the eye to the far left or far right, or have your eyeballs look laterally. This one's also a motor only. Cranial nerve 7 is your facial nerve. It does the taste to the anterior 2/3 of the tongue with the chorda tympani. It will make you cry, taste pie, and taste pie makes you cry, closes your eye. So it has sensory and motor function. So cranial nerve 7 goes through the parotid gland to control all the muscles of facial expression. You probably remember the mnemonic 2 Zanzibar by Motorcar. That's temporal, zygomatic, buccal, mandibular, and I believe it's cervical. And it will help do the parasympathetic action of the submandibular and sublingual gland, and it does the motor function of your stapedius muscle. So if anyone's ever shouting in your ear, you can, or if you're ever at a loud rock concert and you wonder how you don't go completely deaf, that is thanks to your stapedius muscle dampening all of the middle ear bones, or one of them. I can't think of off the top of my head. Cranial nerve 8 is vestibulocochlear. Notice that is 2 different words. We'll get into that whenever we talk about the cranial nerve 8 nuclei. Vestibulo and cochlear. One's for hearing, and then one's for your sense of balance. This one is sensory only, so keep that in mind. We would expect this nuclei to be on the far lateral aspect of the brainstem. Glossopharyngeal, since this one's both, we could expect it to have both a sensory and a motor nuclei being more medial, sensory being more lateral. This one will do taste and sensation to the posterior 1/3 of the tongue. It was responsible for helping the pharynx swallow, and it also does the sensory of the carotid body. So whenever if you were to ever see somebody do a carotid massage to calm down, this glossopharyngeal nerve sends an afferent signal up to the brain to let you know that it's okay to lower your blood pressure and heart rate and slow down your heart rate. And it does the motor function of the stylopharyngeus muscle. We're getting there towards the end. Vagus nerve, aka the traveler, that one's cranial nerve 10 because it has sensory and motor. You could expect it to have a motor nuclei towards the midline and sensory nuclei to the lateral aspect. It above the glottis, it will do the sense of taste. So any sort of like dysphagia, you could expect there to be sort of vagus contributions involved with any sort of dysphagia. It does the levator vali palatini as opposed to the tensor vali palatini. It does what else besides me just reading off here? Oh, and it does all the parasympathetic action of the foregut, midgut. And you could expect the recurrent laryngeal nerve going underneath the aortic arch. So that's always fun. And since we had sensation for the carotid body with cranial nerve 9, cranial nerve 10 is the efferent. It carries out the parasympathetic signal to the heart to calm down. Accessory, that one's motor only, so once again, it's a motor specific one. However, because it's the accessory nerve, how it's from the cervical branches, you would not expect it to have a motor nucleus within the brainstem itself. It tends to be through C1 through C6, maybe a little bit in the brainstem itself. And if you remember from Anatomy Lab, how it comes through the foramen magnum and then back down through the jugular foramen with cranial nerves 9 and 10, respectively. It does motor only of the SCM trapezius. And okay. And hypoglossal nerve is motor only, so we would expect this to be medial only. And it will do any sort of intrinsic tongue movement. So if you were to stick out your tongue and you had a cranial nerve 12 lesion, you would expect it to deviate to the same side. As opposed to vagus, which does like the uvula, so it will do the opposite. So if the uvula is going left, that means it's a right vagus nerve problem, and vice versa. If the uvula goes to the right, then you know it's a left vagus problem, as opposed to the hypoglossal nerve, where it's the same side as cranial nerve 12. So if the tongue deviates to the left, that means cranial nerve 12 is jacked up on the left. And then here is just kind of a quick breakdown of kind of what I've already talked about. You know how I was telling you all of the sensory stuff is going to be on the lateral aspect of the spinal column? Well, here it is. You have your 4 lateral columns. You have your spinocerebellar, your sensory, and your sympathetics are going to be down here, along with your spinothalamic. This is just, once again, kind of a general rule of 4. Versus your midline, you're going to have your motor, like your corticospinal tract, somewhere down here. Your medial lemniscus and your medial longitudinal fasciculus are going to be up here, and your motor nuclei, as opposed to your sensory nuclei, is going to be at the midline. I hope you've kind of caught on to the theme as I've been going through here. And then here, we'll get into this, is the rule of 4. That one's for, I believe, a later slide. But I promise I will talk to you about like the blood vessels. But basically this drawing is the PCA, which is your posterior cerebral artery, will handle cranial nerve, be involved with any 3 and 4 lesions. Your anterior inferior cerebellar artery will be involved with 5, 7, and 8 as far as any lesions, versus on the medial aspect will be involved with the basilar artery. And same with your posterior inferior cerebellar artery for 9, 10, 11. You have your anterior spinal artery doing 12. Okay. So what I included over here are basically MRI pictures of the various sections of the brainstem. You have your midbrain with these cute little cerebral peduncles, substantia nigra here, and you can clearly see cranial nerve 4 right here. Like I said, it was motor only, so you expect it to be just smack dab right there in the middle, along with your periaqueductal gray, and it's going right through here, and you have your superior colliculus up here. I just wanted to show this because this is a great visualization of the red nucleus and how cranial nerve 3 goes right through it. So if you ever had a lesion of the red nucleus or your rubrospinal tract, you should also be wary of any cranial nerve 3 injuries. And this is just to bring up a solid point. Cranial nerve 3's nucleus is called the Edinger-Westphal nucleus. So the big ones for midbrain, like I said, since cranial nerve 1 and 2 go directly to the cerebrum, you'd only have to worry about 3 and 4. The rule of 4 is basically saying that your first 4 cranial nerves you could expect to have involvement with the midbrain. Since I said 1 and 2 go directly to the cerebrum, that only leaves you with 3 and 4. Your pons, for the rule of 4, will get you 5, 6, 7, and 8. And your medulla will get you 9, 10, 11, and 12. Since 11's the accessory nerve, where you would expect it derived from the cervical spinal cord, I should not see them here on the histological views here. But that just kind of is a breakthrough of the rule of 4 and kind of to keep your head straight on what to expect whenever it comes to exams, because honestly, when it comes to exams, you just want to try and find the most straightforward, easy thing. To help you better visualize what's going on with the brainstem as well, here are MRI slides. We have a caudal and rostral pons. You can kind of see that. Here's this big beer belly that will let you know that it's the pons. And here we have the 4th ventricle, so we know that our motor and our sensory of 5 is going to be right here. We have 6, since it's motor only, going to be right here at the midline. 7, since it's motor and sensory, is kind of caught right in between. And then 8 is not pictured here because it is purely sensory, and I believe, I don't have it right here, but know that 8 is further out down here. It's kind of at the pontomedullary junction, so it's kind of at a weird end spot, but you can categorize 8 in the Pons for the sake of keeping the rule of 4 together. Okay, so 2 important nuclei to know whenever it comes to the medulla is the nucleus solitarius. It handles all of the sensory for the medulla. So any sensory for cranial nerve 7, 9, and 10 is going to go through the nucleus solitarius. Any motor for cranial nerves 9 and 10 is going through nucleus ambiguus. I went ahead and highlighted the S for solitarius for sensory and the M for ambiguous for motor. Here you can also see the medial lemniscus for your dorsal columns that we talked about in the spinal tracts lecture, and the corticospinal tract, and we have our spinothalamic out here. So if you had a medial medullary problem, these guys would be affected. However, if you had a lateral medullary problem, say for example your pica or your this is a very popular kind of style question, is your posterior inferior cerebellar artery became hypotensive or ischemic, then you would know that you would lose anything out here, such as your spinothalamic tract, along with your function of your solitarius and ambiguous. So you would see cranial nerve 7, 9, 10 involvement as well with your lateral medullary symptoms. This is just kind of a reminder, and I'm sure you'll go through this with any ophthalmology lab that you'll have this semester, is knowing what the different actions of each of them are, each of your eye cranial nerves. So cranial nerve 3 will handle any motions like medial rectus, your superior rectus, inferior oblique, and inferior rectus. However, LR6, which is this guy over here, in here, and then your SO4, which is going to bring your eye out like that. So a common presentation for an cranial nerve 4 lesion is the patient will have their head tilted to the side of the lesion. That is that way because the eye has to kind of correct for a loss of this muscle here, your superior oblique. So now in order to correct for it, just imagine this guy leaning towards that same side in order for his eye to make the correction. Yeah, and here we have this as well. So in order for it to balance with your cranial nerve 4, because the patient is not able to roll their eye down, instead they will just go ahead and lean their head, so that way it makes sense for them. Because the eye that doesn't have a lesion, they can clearly accommodate for it. Versus the eye that does have the lesion, there's no way that they can make up for it other than just tilting their head. And this is just to kind of remind you what the different palsies look like. Cranial nerve 3 is pretty easy to spot. Their eye is always going to look down and out. And of course the lateral rectus is going to be pretty straightforward. Their eye is just simply not going to be able to look to the lateral side or look outward. And then this, I just wanted to include this question because I know this is a popular board question, is knowing which structures travel through the cavernous sinus, and knowing that cranial nerve 3, 4, V1, V2, and cranial nerve 6 go through the cavernous sinus in case of you ever had like an infection. Okay, so now that we've kind of gone through where we would expect each of the lesions, now we can kind of talk through what is the rule for. So to know which cranial nerves are going to be medial, we already know the rule of 4. We have 1 through 4 is going to be midbrain, 5 through 8 is going to be Pons, and then 9 through 12 are going to be Medulla. But we need to know which one's medial and which one's lateral. Well, with 3 and 4 are going to be midbrain, so they're only going to be medial. But you also need to know if any number through 12 is divisible by 3, then you know it's going to be medial. So naturally, 3 goes into 3, so that's going to be medial. 3 goes into 6, so that's going to be medial. And 3 goes into 12, so that's going to be medial. Everything else is going to be lateral. So cranial nerve 5, 7, 8, 9, 10, 11, they're all going to be on the lateral side. Now you just have to memorize which artery goes with what. And so I provided this picture here just that way you can kind of help visualize everything that's going on. But to find the midbrain lesion that you're going to be most concerned with is going to be your posterior cerebral artery, which is pretty obvious when you see this picture why that is, because here's your PCA, and it's right over the midbrain, which is just above the pons here. So you can kind of see how if you had like a stroke in there, you would have problems with cranial nerves 3 and 4. So your eye would just be basically, because the only nerve that would be working at that point is cranial nerve 6, so your eye would be pulled way to the far left or way to the far right. That's how that would look like. Cranial nerve 6 lesion, instead your eyeball is going to be pulled medial, and that's if you had like some sort of basilar ischemia, more or less like these smaller pontine branches, because I know if you had like a stroke in the basilar artery, you would have something called locked in syndrome, because at that point the only way you're able to get blood in there is through your internal carotid artery. And so the only brainstem function that you'd have is whatever blood the ICAs can get to you, and that's honestly just your eye cranial nerves and a little bit of your vagus through smaller accessory nerves. So if you get a stroke in the basilar artery, it's a pretty bad mamma jamma. For the lateral aspect of the pons, you have your ICA, which is going to be this little guy here. So, So he's going to be, this one right here. He's going to be getting the lateral aspect versus the basilar is going to get medial. This guy's going to get the lateral pons. And then your medulla, you're going to have your pica, which is going to be stemming directly off of your vertebral arteries. So that's going to be getting your lateral versus your anterior or your medial medulla is going to be the anterior spinal artery right through here. So just like with the spinal column or the anterior spinal artery, we'll be getting the front 2/3 of the spinal column. It will also be doing the medial aspect of the medulla. And so that will get your cranial nerve 12 or your hypoglossal. This is just kind of a chart. You'll have to go through it. I'm not super great with your cerebral artery strokes and ischemias. The big thing to know is that Broca and Wernicke's area is going to be on the left cerebrum traditionally. So if you ever had a stroke to the left middle cerebral, you're going to have symptoms of either Broca's or Wernicke's aphasia. However, if you had a stroke to the right middle cerebral, you will have something called hemi-neglect syndrome, where the left side just doesn't exist. If you were to tell them to draw a clock or something, they would only draw numbers 1 through 6, but they would never draw 7 through 12 because the left side of their body just doesn't exist to them whenever they have a stroke to the right middle cerebral artery. And then these ones, a posterior cerebral artery, we already kind of talked about that with the lateral midbrain or the midbrain lesions. But it's also important to know that the posterior cerebral gets your occiput, and so you could expect all kinds of like visual hemianopsias or loss of vision. And I know this one, alexia without agraphia, means you cannot read, but you can write, meaning that you can't read what's happening, but you're able to like write down whatever you're thinking. And those are the only ones I really feel confident kind of talking about. I guess anterior cerebral, because that one, let's see. Oh, we already talked about that, where it goes through, up and over on top of the thalamus, and that we'll talk about our homunculus, where you lose the ability to control your feet on the contralateral side to the stroke. So if it was a left ACA stroke, then you wouldn't be able to move your right foot very well because it will do the motor or your precentral gyrus of your feet. Okay, those are the only ones I feel confident about. These ones, it's just kind of being familiar with the names of them. Those are the things that seem to trip me up the most, to be honest with you guys. The way I kind of remember it is Benedict's is between, so it's Paranod's is in the posterior, and Weber's is in front. I don't have a really great way of remembering it. Just knowing that Paranod's, you lose the upwards gaze, so you can't praise God or you can't look up or upward gaze for Paranod's because it's tackling your superior colliculus, which has a strong relationship with vision. Benedict's, I already talked about this. Whenever you have something, since your cranial nerve 3 is going through the red nucleus, you could expect to have a cranial nerve 3 palsy on that same side. I'm not sure where the contralateral tremor will come from, so since this one is a lesion of the red nucleus on the right, you would expect a tremor on the left. And of course, since the medial lemniscus for the midbrain is here involved with Benedict's, you would expect all of your dorsal column symptoms like loss of pain and temperature and 2-point discrimination and fine touch would be lost on the contralateral side. And then you might get the little tip here, which is your spinothalamic tract of the midbrain, but that's kind of a maybe. And then Weber, since your corticospinal tract is running right through here, you could expect, since this is above the decussation, that you would have contralateral signs of loss of motor function. So since this is on the left midbrain peduncle, you would expect a loss of motor function on the patient's right side. Let's see. Yeah, and this is just a rehashing of talking about if it's in the brainstem, then you would have contralateral signs. So it'd be ipsilateral to the face and then contralateral on the body. If it's in the spinal cord, you'd have ipsilateral muscle loss of motor function and loss of your dorsal columns, but you would have a contralateral loss below the lesion on your pain and temperature with your spinothalamics. Once again, if it's in the cerebrum, you would have upper motor neuron signs on the contralateral side for both the face and the body. And that's it for lesions that I got for you guys. Next up will be eye fields.